views and opinions expressed by guests on this podcast do not represent or reflect the official policy or position of the Take a Paycheck Foundation and podcast. All information shared is from personal experiences and does not constitute medical advice. We do not take responsibility for any statements expressed during the podcast. Take a Paycheck does not endorse any products or services. Any said products or services mentioned on this podcast may not be suitable for you or your condition. Please consult with your physician if you have medical questions, as it may pertain to your condition.
Hi everyone, welcome back to this week's episode on Take a Pain Check. I'm so excited to have Dr. Anna Costello joining me today. Can you give me a brief introduction about yourself? Tell me a little bit about your education, your career, your hobbies, and what you've been up to recently.
Hi, Natasha. Thanks so much for having me, and thanks to everyone for listening. My name's Anna. I'm one of the pediatric rheumatology fellows at the Children's Hospital of Philadelphia. So I'm in my second year of pediatric rheumatology training after doing the whole journey of med school, residency, spending a little bit of time as an attending, and then deciding to come back to fellowship. I would say from a hobbies and fun stuff perspective, my husband and I have a 17-month-old daughter, so a lot of our hobbies are driven by her nowadays. She is in just an adorable phase of talking and exploring the world and learning new words. Fish are really big right now. She calls them fish. So like dolphins are big fish. She's just really, really cute and fun. So that's like the biggest thing I've been up to recently is just enjoying that.
That's great. Thanks for sharing. And so you are currently a rheumatology fellow. So how did you actually know you wanted to first study medicine and then study rheumatology?
Great question. I think I was interested in medicine initially pretty like early in childhood, early teenagerhood, because my neighbor who was really, really close to me, my dad's family is all in England. So most of my like actual relatives lived really far away. And so my neighbor was sort of like my grandfather figure. And he had really advanced metastatic colon cancer that had gone to his liver and throughout his body. And so I sort of throughout his treatment learned a lot about his treatment team. And so I first became interested in oncology, but knew I loved kids. So thought I'd do pediatric oncology. And he gave me books to read about his treatments. And so really sort of engaged me in what medicine was. And I thought it was so important. And throughout sort of medical school, and as I went further into residency, rheumatology became an area of interest. I kind of like the mystery of rheumatology. It often takes a long time for kids to get diagnoses. You use labs, you use your physical exam, you use a whole really detailed history. And so I was really interested in those diseases. And so sort of over time, my initial interest in oncology morphed into more of an interest in rheumatology, though it certainly took me a while to get there because I was a general pediatrician for a while too. And so I think one big message I'll say for people who are thinking about medicine is I think that we always think everything's really linear and that everybody like, you know, they want to be a surgeon and then they become a surgeon. Or like you match in one field and that's what you're going to do for the rest of your life. And for many people, that's the case, but not for everyone. My husband switched residencies. I've switched career paths. And so a lot of people make changes. So don't feel like if you make a choice, it has to be your forever choice.
Yeah, I think that a lot of people, especially in like the medical field, when they are studying, I think they are kind of hesitant to decide what they want to do because they feel like they might have to like stick to it forever. But it does sound like people can change their minds. And I think even over time with experience, you kind of get a sense of what you want to do even further. So I'm wondering when you decided, you know, adult care versus pediatric care, and now there's also like med peds, like how did you decide I want to be a pediatric rheumatologist versus an adult rheumatologist or like focus on transition of care?
Yeah, that's a great question. I mean, I think it varies for different people. So like some people pick their subfield first and then think kids versus adults. Some people pick the big kids versus adults decision first and then decide what their subspecialty is going to be. I mean, I think for me, I have always just like loved kids. And so I came into med school thinking I would do something in peds. And then there were other fields that appealed to me along the way. And I definitely thought about other things, but I always came back to like really liking kids. And I know a lot of people say like they don't want to be pediatricians because of the parents. And for me, I really liked the interactions with working with the whole family. And so that really spoke to me a lot. there are great things about adult medicine, but adults don't take care of themselves. And parents typically want to take care of their kids. And I really like that about pediatric medicine. Like, if we find a problem and we have a solution, the family will normally actually do the solution and the kids get better. And kids are so resilient and so fun. So for me, at the end of the day, like going into a children's hospital and having kids like giggle and say weird words during visits was like what I wanted, and it makes me happy at work. I think great question about like med peds. That's a whole new-ish field that more and more people are doing. And I think it's an amazing addition, particularly for fields like rheumatology, where transitions of care are such a big thing. And so those folks have a tremendous training in both adult and pediatric medicine. And then some of them go on to do subspecialty training in either one or both sides of the spectrum. So that's another amazing option that I don't think I knew much about and probably would have made me really confused. So I'm kind of glad I just kept it simple.
That's really interesting that we even bring this up, because I didn't know it existed, and I think a lot of people still don't know it exists. So like raising more awareness that something like this does exist, like especially in Canada, I don't think it's a thing. Like we have transition clinics, but the transition clinics have a pediatric rheumatologist, an adult rheumatologist, a physiotherapist, whereas I've heard like now in the States it's a little bit different, where someone can actually like specialize in that. And so I'm wondering, like, could you talk a little bit more about how that works? I know you have colleagues in that field, so what does their day-to-day look like versus yours?
So we have 3 fellows actually in my program of 9 of us that are med peds trained. And so the way it works here, though I'll say it is like different from field to field. So med peds people, just to start, can decide to practice just medicine or just peds or both. So some people go on to be like a primary care doctor or a hospitalist and they see both. Some people decide, hey, I'm just going to do the adult side, just do the peds side. Same thing if they decide to subspecialize. So some people, actually, I know someone I did residency with, he did med peds, but he's just going to do adult rheumatology. He's glad he has the background of pediatrics, but he's not going to do both subspecialty training. Then there are other folks who may pick just peds. And then there are other folks who decide they want to do subspecialty training in both. So the way that works is it makes your training a little bit longer. So here, pediatric rheumatology training is 3 years. Adult rheumatology training is either 2 or 3. And if you do both, it takes a total of 4 years. So those fellows, and this structure of this is very different from program to program, but effectively they'll do clinics on both sides. And then typically we'll do like 1 year that's more immersion in pediatrics, 1 year that's more immersion in adult rheumatology. And then their other 2 years will be used for like research and projects and flushing out the experience on both sides. And so, for example, my colleagues who are med peds trained, like every week they have at least 1 clinic on the ped side and 1 clinic on the adult side. And then they also sort of split the burden of covering the hospitals on both sides. So they get tremendous exposure. And for them, when their pediatric patients grow up, they just swap which clinic they see them in. So we don't have like a clinic necessarily where just the med peds people work, but they, if they have a patient with lupus, for example, who ages out of the pediatric side, they can just see them over in their own adult clinic without transition. So it is like a really, really wonderful resource for the person who's doing the training. It's a lot of time, right? They have 4 years of residency instead of 3, 4 years of fellowship instead of 3. So it is hard, but it is definitely an amazing resource. And I'm really happy when I can refer my kids who are leaving the peds world to an adult rheumatologist who at least has some peds training and can sort of understand their childhood experience.
I think that also gives patients a little bit more reassurance in a way too, that, this person actually specializes in both fields, because I think as patients, like transition of care in that certain time frame is very hard. Like not only are you changing care, but you're also like moving out to go to college or university, and you need to figure out like drug reimbursement, like all these like different things as you grow up. So having more reassurance of like your physician is super helpful. But just knowing that, I think on the other hand, when we don't have people who specialize in this field, having that communication from a pediatric rheumatologist talking to their adult rheumatologist is also very reassuring. When you do see patients that like transition care, what is the communication like between you and potentially like an adult rheumatologist, or like what have you been trained to do?
So, I think every program probably has their own strategy for that. Here we try to start talking about it early, right? Because like you said, it's complicated, it's scary for people, and it can take a while. Like wait lists for adult rheumatologists are really long. So we try to start like a good amount of time before we actually need them to like not follow with us anymore, to start talking about it and ask them to identify a provider. Sometimes if it's a transition we're really worried about, we'll have them come to a visit. They have to sign like release paperwork so we can send all the records over to the adult rheumatologist. We'll tell them, go to your first visit and then come back and see us one more time so that we can make sure it went well. If a patient is like really confident and comfortable, maybe their family member has a disease, they're going to a doctor that they already know, like it doesn't have to be that big of a deal. And for some people it isn't a big deal, but for our patients that we're really worried about, we try to be really careful about that process. And rheumatology, particularly pediatric rheumatology, but in general, it's a small community. And so like I have a patient who recently transitioned, and for a period of time, we're kind of like co-managing, like the patient's seeing both of us. And so we send emails back and forth and like talk about it. It doesn't have to be all or nothing. So I think you have to be flexible based off the situation, but for most patients, we can make it work.
Yeah, it sounds it's very individualized per patient and their family and everything. Like if the family is more I guess there's patients in different environments, and like how they grow up to actually learn about their arthritis or rheumatic disease is very dependent on like how they will be. I think for me specifically, like for example, I at first did not want to learn about my arthritis at all. But when I started to actually like read about it more, I feel like my parents were also more reassured that I would be okay, like being able to transition. And even though my mom still attends my appointments because she drives me there, like I think that knowing that, she won't always be in my appointments, like would I be able to still manage my own care? Like it takes time to kind of get to that spot. And it's nice to see that the physicians are really caring about their patients and making sure that they're supported in every step of the way, even though it may take a bit more time. I kind of wanted to talk about where you work specifically. So you started at CHOP in 2016. Why did you choose this hospital specifically? And is there anything like unique about it or something that you really like about the work environment that you're in?
So, the process here in the States is like you do med school, it's 4 years long, then you do like this horrible match where you submit a list of residencies you're interested in, make a list of the candidates they're most interested in, and then like a computer tells you where you're going. And I made that process more complicated because my husband's also in medicine. And so we did what's called the couples match, where like we submitted combos of programs and they submitted a list of us, and the place that wanted both of us is where we went.
Oh, that's so interesting. Like I've never heard of that. Okay.
Yeah. So it makes it really complicated. So we submitted a list of like 99 combinations of programs. It would be like in Philadelphia, I interviewed at the Philly area, I interviewed at 3 programs and he interviewed at 4. So it was like all those combos. And so for us, it was kind of like a household decision in that we needed to pick a program that we both liked. And at the time, he was actually in emergency medicine, though he has since switched and now is also a pediatrician. He practices pediatric sports medicine. So we both see kids with joint problems of different varieties, which is super fun. But when we were applying, he was applying in emergency medicine. And so Philadelphia had a great program for both of us. And so finding that place where we both found a program we really loved was hard. And so we both really loved the programs here. I think residency is a time when you work really hard. And so being near your support system is also important. So for us, our families are like 2 hours or so from here. So we'd still be able to see them easily, travel to get home. So that was really important to us. I think valuing like your wellness as you make these choices is super important. In terms of what CHOP offered, CHOP's a really unique place. It's a huge children's hospital. It has so many subspecialties and subspecialties. So I was really excited for sort of the depth of training that I could get here. World experts in everything, all the research, all the diseases. But I was also happy because it is like the local hospital for the children of Philadelphia. And so you get a really nice balance of sort of bread and butter, like basic medicine, asthma, and even within rheumatology, like the more common rheumatologic diagnoses. But you also get to see these second and third opinions from around the world. And so that balance really appealed to me. And it was a great place to train. I loved it, which is why 7 years later, I'm still here.
No, that's great. And that's so interesting that you brought that up because I didn't know the whole couples matching thing, but that must have been like lots of thought put into it when you actually have to, because not only is this computer like telling you where you're going, but it's also telling you where your husband's going too. So lots of planning that could maybe even help other people who may not even have known about that if they ever want to get into like residency and fellowship and all of that. But you also worked at the pediatric hospital medicine for many years, and then decided to pursue a fellowship. So, what was the reasoning behind this decision?
Yeah, so I did my 3 years of residency, and then I did a year of what we call chief residency, which is where you kind of do a whole host of tasks. You do a lot of administrative stuff, kind of running the residency program, be that educational stuff, scheduling, sort of managing the residents. But you also do a lot of sort of work on the hospital level with how the residency program interacts with the hospital as a whole. So that was a really amazing experience. I did it during the start of the COVID pandemic. So we had to make a lot of pivots, a lot of changes. And I definitely learned and grew a lot from that experience. As my chief year ended, I had throughout residency thought about either doing pediatric rheumatology or being what we call a pediatric hospitalist or a hospital medicine doctor, which is where you're sort of a general pediatrician caring for hospitalized children. And those two fields really stood out to me because they have a really big depth of diseases they care for and breadth of diseases they care for. And I really like the diagnostic process, like thinking through what's wrong with kids and helping figure it out. There's a lot of that in the hospital. And so I decided I was going to be a hospitalist. I spent a lot of my time chief year working as a hospital medicine attending, and then 2 more years after that as a hospitalist. And I really loved it. But I missed sort of long-term relationships with the patients because you only care for them when they're in the hospital. So like I'd get so attached to these families and then they'd leave and I wouldn't know what happened. Like if they followed up at my hospital, great, I would see their outpatient notes, but I wouldn't, if they lived far away, like you wouldn't necessarily know, like, did they get better? What happened? And two, like you made this relationship and you never saw them again. And so I really missed that aspect. And I thought that rheumatology would be a good fit once I realized that I was missing that, because you still get this really great diagnostic process, but you get to go a little bit more in depth in one area and you get to follow these kids over the span of time. So we care for really sick kids in the hospital, but we also have patients that we only ever meet outside the hospital and we follow for years and years, or vice versa. Like if I see a kid in the hospital, they can come see me in clinic and I can have that relationship with them over time. So I think that was like the biggest driver for me of making a career change. There are lots of other benefits of doing fellowship too. But I think for me, sort of wanting a change to what I was doing clinically was sort of the biggest driver. And I've been really happy with that change and getting to live in the outpatient world, not just in the hospital.
Can you share maybe like an eye-opening experience that you've had during fellowship?
Yeah, absolutely. I mean, I have learned so much in fellowship. But I think one thing that's really interesting and really pressing in rheumatology is there's just like not enough pediatric rheumatologists, which hopefully will speak to some of your listeners who probably had a long time before they got diagnosed with their disease or have to travel really far for their appointments. And so I think one thing that's been incredibly striking to me since starting rheumatology fellowship is just like the journey people go on before they get to us, right? I mean, I think about so many of my patients who have gone for months to years with limp and weird symptoms and been told, oh, maybe it's a fracture, oh, maybe it's a sprain, oh, maybe it's this, maybe it's that. They got put in a cast, then they got blood work done, and they got an MRI, then someone tapped the joint, no one knows what was going on. They got passed from orthopedist to primary care doctor to the emergency room before they get to us, and we find out that they have JIA, which is like a treatable disease that we can make better pretty quickly for most people. And so I think that for me as a hospital doctor, I'd worked in this environment where I was at a huge hospital with a ton of resources, and like everything was sort of at my fingertips, and seeing what patients go through, and I'm at a place where we have plenty of rheumatology access, right? We have a state where we have lots of rheumatologists, and even here, seeing the journey that people go to get to that diagnosis has been really striking to me, and something that I hope that I can think about and learn about with my career to make better, because I think it's a pressing issue, especially with our sort of workforce shortage of rheumatologists.
On top of that, this kind of resonates with me just because so many guests on the podcast have kind of mentioned their journeys of being diagnosed after 6 years or 8 years. And I'm like, I'm really grateful because I got diagnosed in less than a month. But that's also the difference between like Canada and the States, and also globally. Like there's so many different challenges of where you are, where you live, the access to care. So it's really a tricky topic, and hopefully we'll be able to find more solutions just so like young people and also anyone that needs to get diagnosed gets diagnosed very quickly, because I see people talking about how they have more damage in their joints just because they were not able to see a doctor as quickly as they could and get on medications. And it's just really hard to even like express how that feels like, because they're also very frustrated, but they need answers as soon as possible. So just like working together to find solutions is like, would be really, really helpful for patients.
Yeah. And I think for me, that was, so when I was a hospitalist, one thing I was really interested in was diagnosis. Like, how do we make diagnoses? How do we do that better? And in hospital medicine, it was hard because like the number of diagnoses we were looking for was everything, right? Like they were general pediatricians, we're searching for everything. And so thinking about that process. Now that I've switched to rheumatology, this issue, exactly what you said, is you just hear these people's stories that break your heart, or kids who, were walking and they stopped, their toddlers, they can't say they have pain, they stop walking, and then they start only crawling, and then they stop crawling on their hands because their wrists hurt, and they start crawling on their elbows. And like, how much does that affect? You have joint damage, you're not walking anymore, right, at a stage where you're supposed to be learning these skills. Like, how much does this affect your development, your growth, your childhood, your ability to do what you want to do? And so, as I'm going through my fellowship, our second and third years are dedicated to research. And so the area that I'm really interested in, and I'm starting a research project on now, is sort of looking at exactly this, like diagnostic delay in JIA, and how do we get kids to a diagnosis earlier. And we know very little. Like you hear the stories all the time, I hear the stories all the time, but we don't really have a lot of information. Like there's not papers published that say like what's happening to these kids, who's seeing them, where are they going, how could we get them here sooner? And I think the solutions are going to be different at different places, right? It's different if you're in a healthcare system that is a like single payer or socialized healthcare system versus a more privatized healthcare system. It's different if you're in a state with a rheumatologist versus a state without a rheumologist. So I don't think it's going to be a one size fits all solution. But like you said, the longer you go undiagnosed, the worse the damage is that you have, and the harder it is to treat your disease. And as we're getting more efficacious therapies to treat these diseases, finding the patients so we can treat them becomes increasingly important. And so as I move through my fellowship and sort of into my career, I'm hopeful that I'm going to learn the skills to sort of study this and figure out why we're seeing these delays and how we could address them in different ways.
Yeah, no, that's amazing. And I'm so glad that you're passionate about that, just because you're right. Like we do have these medications, but then it's like, okay, now that we have these medications, like what do we do with them if we don't see the patients that actually need them? And so like trying to find the root cause, and I think like finding the main cause of like lots of things would be super helpful for patients in general with any sort of diagnoses, but finding like why they can't get to their rheumatologist as soon as possible? Like, who are they seeing that may be taking care of them, and like why didn't they get referred to a rheumatologist? Like I feel like there's so many questions, and I think that also calls for like lots of research projects, as you mentioned, and like lots of research questions to be answered. But I think it's really nice for patients at least listening into this, knowing that there are rheumatologists and researchers who are actually now like looking into this topic to ensure that there are solutions in the future that are personalized to different patients so they're able to get like access to care as soon as possible. So thanks for sharing that. And hopefully they have more sort of like courage and like don't stop, because I know that there's lots of patients that also start in pediatrics. When they transition, they kind of like drop off from their care because they don't have the time, the money, even just like the energy to figure out how are they going to now go to this new doctor and like re-explain their whole story. And then there's also cases where they haven't even seen a rheumatologist yet, and then they like pop into adult care, and there's like so many years of where they could have been treated but they just weren't. So it's just like it's so interesting to know that there's like research being done on this.
Yeah, and you're so right. There's like, my interest is sort of that upfront period, but there is this whole other period that I know, around transitions of care, there's a lot of work being done, because that's another place where people get lost. So people that had their disease under control get lost as they go through some of those transitions. And definitely, yeah, I think, in healthcare, there's lots of different types of research, right? There's like basic science, which is working in a lab with mice or cells, trying to figure out how the immune system works, or how whatever other system you're interested in works. And then there's what we call sort of translational research, which is trying to connect what you learn in the lab to sort of more clinical, like what we see in the clinic, developing medications, sort of trying to think about maybe how things they discovered in mice or in cells we could use as a blood test that helps us understand patients. Then we talk about clinical research, which is sort of, what medicines works best for what condition, what do we see in this disease? And then I think there's sort of like even another step, which is sort of what more this is about, which is like, how does health care actually get delivered? And yeah, we can have the right medicines and the right treatments, but like if we're not getting them to the right people, how does that look? And then sort of even a step above that, like the health and safety of populations. And so I think, every field has their own skew towards different parts of research, and they're all important. But I definitely think thinking about, we develop all these effective things, but actually getting them to the right people and how we do that efficaciously in the way that's least painful for patients is really important and really matters too.
And I guess I also just wanted to talk a little bit about like how you as a physician would go about even like diagnosing a patient, or like what would you order, what would you see? How do you examine a patient to even know, okay, there is something that is wrong with them. It could be related to arthritis or rheumatic disease. Like what is the method that you take or the process that you take to diagnose a patient? I know it will be different for everyone.
So I think in rheumatology, like the history gives us most of the information. And I think that's one thing that stands out as something that a lot of these patients before they get to us who have JIA or other autoimmune diseases have had like a million labs and a million MRIs and people stuck a needle here and stuck a needle there, and like great, but actually a lot of these diseases we can make most of the diagnosis just with talking to the patient and doing an exam. So like JIA, we say it's a clinical diagnosis, meaning like there's no test that's going to tell me yes or no. Really what's going to stand out is like, do you have morning stiffness? Do you have effusions or swelling in your joints on exam? Do you have joint contractures? Some of these things we look for on exam. And so, I think a lot of times when people get referred to us, it's really helpful to just take that deep dive into the history. Things like family history, autoimmune diseases run in the family, maybe a little important. I think a lot of folks think it's like so important, and like half of my referrals are like autoimmune diseases in the family, and it's like might make us think about it a little more, a little bit less, but like really what I care about is that specific patient's symptoms. And then our physical exam is like really head to toe. We look at the eyes for signs of uveitis, for lupus. There's certain types of ulcers. There's certain types of rashes. And then the really thorough joint exam. And that gets us like 95% of the way there to the answers we need. There are times when lab tests are really helpful. For JIA, they're more helpful at thinking about the type of JIA the patient has, as opposed to like being the test that says yes or no, they have it. It more helps us like characterize their JIA. For diseases like lupus, they can be more helpful and more diagnostic. And then imaging can be helpful, particularly when your exam is hard. So there's like the toddlers who just scream no matter what you do. And like, you're like, I think they have a joint effusion, but I can't really tell. So there are some times when imaging can be really helpful. I'm currently getting trained to do point of care ultrasounds. That means like ultrasound in the clinic so we can look at the joints ourselves in real time. But things like MRI can be even more helpful for really detailed imaging. So it definitely depends on the diagnosis. It depends on the kid, but I would say like a rheumatologist taking a history and doing an exam is going to get you a lot of the way there. And I do sometimes feel sad that kids have gotten so much done before they get to us. I'm so happy when people rule out Lyme disease and infections before they get to us. But sometimes they've had a lot of testing that I'm like, oh, they put you to sleep for an MRI. And like, all I would have needed in the office is just to kind of feel your joints and move them around. So I think a lot of our diseases, that clinical piece, just like what we see and feel, is the most important.
As a rheumatologist, because like all these rheumatic diseases have different symptoms, what other specialties do you communicate with when you have to like treat your patient? Because I'm assuming that when patients are diagnosed with rheumatic disease, they have multiple symptoms, and not all of them are directly related to rheumatology, or if they are related to rheumatology, they can also be referred to another specialty. So how does that work in terms of like collaboration on patients?
That was definitely one of my favorite parts about rheumatology. Is in a way, you're still a general pediatrician, right? Like our diseases affect so much of the body, and we work with a lot of different types of doctors. And so different diseases affect different parts of the body. I will say in the hospital, we overlap a lot with like infectious disease doctors, oncology doctors, because a lot of those conditions like systemic JA or lupus, they can present with fevers and these sort of vague symptoms, right? And so at the beginning, you're thinking about those big buckets. Do they have an infection? Do they have an autoimmune disease? Do they have cancer? And so we overlap a lot with them. Once patients have a diagnosis, as rheumatologists, we manage the autoimmune disease, but the disease might affect other organs, right? So lupus can affect the kidneys, so we'll work really closely with the kidney doctors. Kawasaki disease can affect the heart. We work really closely with the cardiology doctors or the heart doctors. Inflammatory bowel disease, which is a disease the GI doctors, the gastroenterologists treat, can also cause arthritis. And so we sometimes co-manage those patients with them. So we have a lot of overlap. And then, my household bias living with a sports medicine doctor or an orthopedic doctor is that, we also see and treat a lot of joint problems, right? So sometimes those kids truly have JIA, but they've been seeing an orthopedist, and vice versa. Sometimes kids see me and they just have flat feet or like apophysitis, which is a really fancy word for like a really common problem of childhood, sort of at the site where tendons attached to the bones, being like extra force on those areas. And so there are so many overlaps that we have, which is one of the things that really appeals to me. That we get to work with this huge host of doctors, and we have conferences with a lot of them here, and I'm sure most rheumatology divisions do, so that we can all keep learning from each other. And I think that's one of the great parts about medicine, right? Is like you're learning forever. And in rheumatology, it's really nice that we get to learn from like a whole host of people. And I didn't even list like ophthalmology. Like we see lots of uveitis. I met you because I met your sister, who's a dental resident, when I met her, because our patients can get jaw disease. So, really the overlaps are tremendous because our diseases affect every part of the body. And that's one of the great parts of our field, I think.
We did meet each other through my sister, who is at UPenn in residency as well. So that's pretty interesting, like just how the specialties combine together, like you give referrals to each other. So a very unique way to meet someone. But I'm glad we're here. And I also wanted to talk a little bit about your master's program. So you're currently in a master's program. Can you talk a little bit about that as well?
As part of fellowship, most fellowships, you have like 1 year that's really heavily clinical, where like last year I was a clinical fellow, like 1 week in clinic, 1 week on service, on service, meaning like taking care of the kids in the hospital, alternating back and forth for the whole year, pretty much. And then our second and third year are more dedicated towards research and sort of developing what you want your career to look like. And that can mean a whole host of different things depending on where you go to fellowship and what your interests are. But for me, since I have this interest in sort of diagnosis and JIA and like how we can learn to understand diagnosis, there's sort of two additional things I'm doing this year. So one is I'm working with a group called the Society to Improve Diagnosis in Medicine, which is a national organization that has a tremendous patient component and then also physician component that does a lot of research related to diagnosis. And so I'm a diagnostic excellence fellow with them, and they're giving me some mentorship and training to learn how to study diagnosis. And I'm actually going to one of their conferences this weekend, so I'll get to meet a lot of them and present my work and hear about other people's work. And then the second piece is I'm doing a master's program at Penn called a Master's of Science in Health Policy. And that is a program that effectively teaches you research skills. Like as doctors, we all talk about doing research, but like it's not what you learn in med school. In med school, you learn anatomy, you learn physiology, you learn, you go through all the different subspecialties. And so learning the skills of statistics, how to design research studies isn't really something that most of us have formal training on. And so some people do that sort of just through mentorship, throughout fellowship. But for me, CHOP has been really great in helping me, in supporting me in doing this program. So I like take statistics classes. I have a midterm next week, which is very bizarre as someone who's like as old as I am and like have a child and I have to like study for a test, but here we are. So, I'm learning things and learning skills that will hopefully make me more able to do sort of the research I want to do and to tie that into the field of rheumatology. And so fellowship is a really nice opportunity to develop those clinical skills, but to also develop sort of what you want your niche to be, whether that's to be a better educator. Some folks take like classes about teaching and classes about curriculum development, or to learn how to do research or learn how to work in a lab, or, if seeing patients is going to be your day in and day out, really diving into that and seeing more patients. And so certainly I still see patients and do patient care, but I'm doing this stuff sort of in addition to try to learn those skills so that I can maybe help tackle some of these issues.
Can you give me a rundown of a day in your life? I know it might be different like every single day, but just pick one day and kind of just go through it and what it looks like for someone who is a fellow.
Yeah, absolutely. So, I think this year when I'm doing sort of a combination of school and clinic, like for example, on Thursdays, I have class in the morning. So I go to the Penn campus and I go to a methods class where we learn how to design research studies. And then I go to a statistics class where I learn statistics. And those classes are each like about an hour and a half long. So that takes up most of my morning. And then I run over to our clinic site and I have clinic in the afternoon with one of our awesome attendings who supervises me. And so I'll see like 4 or 5 patients with him in the afternoon, and learn how to care for patients. And then sort of at the end of the day, I will sit down and write my notes and call back any families that have called me. Today, you could probably tell from my background that I'm at home. So on Fridays, I don't have class or clinics. So that's often a day where I like do my classwork. I will actually do the research projects that I'm supposed to be doing. But I also like had a patient with a new diagnosis that I spent an hour on the phone with this morning, just sort of talking through the labs that came back after I saw her on Monday this week. So I spent like an hour talking through the labs that came back with her family. And then I did some homework, and now I'm working on some of my research projects. So every day is a little bit different. There are weeks, for example, in 2 weeks, I'm on service for the hospital. So for 7 days that week, I'll be on call 24/7 for the hospital. Not that I'm in the hospital 24/7, but like when I'm at home at night, the ED can call me. And then every day I go in and round on our patients in the hospital. So every week is a little bit different and super variable, but learning a combination of skills and hopefully I come out of it being able to do all the things I need to do for my job.
It sounds really fun. Like the way that you're just describing it, like the variety of different things that you do, and that's not the same every single day. It sounds very fun. I'd love to do that. I'm like, it just sounds so exciting because you are not only, well, first you have a midterm. That's kind of funny that you have to do a midterm, but it's interesting to like hear you study in the mornings and then go to clinic, and then like on other days you're like working on research projects, and then Like it keeps things exciting is what I'm thinking. But like, how do you like the variability of like what you do?
Yeah, no, I think that was one of the benefits to me in coming back to fellowship. It's like if you are a primary care doctor or a hospital doctor, unless you do a fellowship of some sort, really you just jump right in, right? And like you're seeing patients all the time. Like when I was a hospitalist, I was like 40 hours a week or whatever I was paid for. I saw patients in the hospital. And so you don't have that variability. And like, don't get me wrong, every day in that job is very different, but it's hard to learn new skills, right? Like you don't have the time to, on top of that, do a degree or, have this time to kind of decide if you like doing things. And I think one of the reasons I decided to go back to fellowship and something I've been really enjoying about it is that ability to just have time for like your own growth and your own education, and just sort of decide what you want for your career. So like I'm trying to do research, and like if I don't like it and then at the end I want to go back and see patients 5 days a week, great, like I'm trained to do that. But it gives you this ability to explore and develop new skill sets, which is really like a luxury in a lot of ways. There's plenty of things that are wrong with fellowship, but I think that is really a luxury that you can't overstate the value of having 2 years where like kind of your time is your own and you can develop and learn these new skills.
So I wanted to end off the podcast episode with an advice segment. So what advice would you give to those who want to pursue a career in the medical field and specifically rheumatology?
I think it is a hard path, but it's a great path. So you probably hear people talk about residency and how tiring it is, and all of that is super, super true. But also you get to take care of people every day, and you get to see people at their most vulnerable moments of their lives, and help make them better. And so there's an incredible privilege in that. And so I think, if that's what you want to do, then it's worth it. But I do think you have to be really cognizant of taking care of yourself in this process. And I think, in medicine and anyone who goes into higher education, it's really easy to get sucked into like, you always want the best, the best degree, the best school, all those things. And while that is true, you have to take care of yourself. So like, I think I said when we were talking about like the match and applying to residency, like think about where you want to live. Like, who's going to be near you? Like be near your family if that's what matters to you. Be near your friends if that's what matters to you. Like find your support system, lean into your support system, and don't let like kind of the rat race of trying to learn the most and get in push you away from like your values and what really matters to you.
Thank you so much for joining me on today's podcast episode. We had a great conversation about your interest in medical school and then how you knew this was what you wanted to do. We talked about your current fellowship, how you transition from the working world back into education as well. You talked about your personal life and how you manage your own health amongst your patients. We dived deep into your research interests and how you plan on continuing to research and study on diagnostic delays in children with JIA. And last but not least, we talked a little bit about some advice for medical students. So everyone make sure to like, comment, subscribe, share this episode, and I'll see everyone in 2 weeks on Take a Paycheck. Thank you so much. Bye.
Thanks for having me.